My case presentation regards a 72-year-old postmenopausal female who presents to the clinic for her routine well women's exam and as well as a refill of her estradiol for hormone replacement therapy. She complains of having hot flashes, insomnia, and vaginal dryness and reports great relief through the use of her estradiol. She's a G2P2 with a history of 2 uncomplicated vaginal deliveries at ages 26 and 28. She has a history of hypercholesterolemia, hypertension, and hypothyroidism, and she had a total hysterectomy with a bilateral salpingo oophorectomy in 2010. Her last menstrual cycle was 20 years ago in 2000. She has a known allergy and currently takes Crestor 25 milligrams, Lipitor 10 milligrams, and Synthroid 88 micrograms daily. And then she takes her estradiol 0.01% vaginal cream, 1 gram 3 times weekly, and estradiol 0.5 milligrams orally daily. Her last PAP was at age 65 and she has no history of any abnormal results. Her last mammogram was unremarkable in September of 2019. She received a bone density screen in 2018, which was indicative of osteopenia. Therefore, she was referred for Prolia injections based on her elevated FRAX score. Her last colonoscopy was 2 years prior. She had a pneumonia vaccine at age 69 and declined the flu vaccine. She denies any family history of cancer or chronic illness. She's been married to one partner for over 50 years and denies being currently sexually active. She does drink wine twice a month, but denies any tobacco or illicit drug use, and she does report that she completes self-breast exams monthly. Her vital signs were a blood pressure of 125/82, heart rate 77, respirations 18, temperature 97.5, weight 144 pounds with a BMI of 25.28. Her thyroid was non-tender with no nodules or masses. Her breasts were symmetrical bilaterally with no skin changes, discharge, and her nipples were without deviation or retraction. No masses or tenderness were palpated. There was no lymphadenopathy in her axilla. Her abdomen was without any rigidity or guarding, and there was no masses palpated. There was vulvovaginal atrophy and dryness present. No vaginal discharge, tenderness, or masses were observed. Her uterus was absent. She had no adnexal tenderness or masses palpated, and no inguinal lymphadenopathy was present. No diagnostics were needed at this time. So regarding this patient's age as well as her risk factors, shared decision-making can be utilized regarding continuance of hormone replacement therapy for her postmenopausal symptoms. Differentials of these symptoms include thyroid disease. As she is already diagnosed with hypothyroidism and she regularly follows up with her primary care provider, this is less likely. Second differential is pheochromocytoma, and this is due to her generalized sweating, which is a sign, but the classic triad of this disease includes headache and tachycardia. Thirdly, carcinoid syndrome. The hallmark of this is flushing, but it's typically accompanied by a decreased blood pressure and a rise in pulse, which this patient is not exhibiting. So the plan was we refilled her estradiol, and we gave her an order for her mammogram and DEXA scan and discussed the importance of taking vitamin D and calcium. We also had an extensive discussion regarding the potential risks of continuing hormone replacement therapy, such as increased risk for breast cancer, heart attack, and stroke, especially regarding her history of hypertension and hyperlipidemia. Per the guidelines, the lowest dose should be given that treats a patient's symptoms, and this patient had actually tried to wean down a couple months prior to 0.5 gram 3 times weekly, but stated her symptoms were just intolerable. So as she does not have a uterus, she is just taking estrogen without progesterone, which is appropriate per guidelines. And according to NAMS and ACOG, they both agree that postmenopausal hormone therapy should be individualized, and you should have this discussion with your patient regarding the risks versus benefits. It is also important to just plan and have that discussion about attempting to wean or to stop in the future. What I learned through this is that hormone replacement therapy can be kind of scary because there are so many risks that go along with that, but it is important to weigh the risks versus benefits with your patients and just to give them all the facts. And for this patient, the quality of life was worth the risk. I also learned that this can benefit her osteoporosis.